Hello, I'm Dr. Frank Piccini. This is my presentation from ASTRO 2023. I gave a talk looking at the limitations in the application of clinical pathologic factors alone in predicting radiation benefit for women with low-risk ductal carcinoma in situ after breast conserving surgery. I'll be specifically looking at the impact of a 7-gene biosignature based upon 10-year rates of ipsilateral breast recurrence. These are my relevant disclosures. Just as background, we all know that adjuvant radiation reduces in-breast recurrence for women with DCIS, but it's important to point out that about 70% do not have a recurrence after surgery alone and therefore would not benefit from radiation. So overall, about 15% of patients benefit from radiation for about a 50% relative risk reduction. And of course, radiation does not improve survival because the overall survival is superb. So if the majority of patients don't require radiation therapy, how do we identify those patients? Well, in the past, we all know that clinical and pathologic factors have been utilized to identify a low-risk population of patients who don't benefit from radiation, and they're indirectly assessing tumor biology, of course. We've used such things as tumor size, family history, palpability, patient age, etc., and nuclear grade. And over the past 25 years, clinical pathology factors have been put together into various categories to identify these low-risk patients. These are the various factors and criteria and nomograms that have been used over the past 25 years. We're all familiar with them, the RTOG criteria, ECOG, Memorial Sloan Kettering, and the VNPI, the Van Nuys Prognostic Index, excuse me. There's concerns with these low-risk criteria and these nomograms, of course. There's no single factor criteria or nomogram has consistently identified a low-risk group that does not have a clinically meaningful benefit from radiation. There's problems with reproducibility, inconsistency of the application, and of course the assessment of histopathology, particularly nuclear grade. That's been very inconsistent and discordant. So therefore, there remains a true need to identify tools to help better identify those patients that truly do not need radiation. And this is really what led to the biosignature development that we'll talk about today. A lot of the pioneering work was done at UCSF and Yale, funded initially by an NCI grant, and it really led to the development of the 7-gene biosignature we use today, more commonly known as DecisionRT. The DecisionRT test is a 7-gene predictive test. It comes up with a decision score. It combines 7 biomarkers with 4 clinical pathologic factors. It's been validated through published studies as both prognostic for ipsilateral breast recurrence risk, as well as predictive for RT benefit, and identifies patients with an elevated recurrence risk as well after breast conserving therapy with radiation. And these are just some of the things that the 7 genes look at. Of course, the stress response, HER2 and KRAS, hormone receptor, cell cycle control, and proliferation. So now the study population that was used in this analysis, it's a pooled cohort of multiple patients that were used in the validation studies. Those validation studies were published, as you can see here on the right. They were all verified to have DCIS without microinvasion, no prior history of breast cancer. They have 10-year follow-up, which is really important, and they have complete biomarker and clinical pathology. And when we combine the full 4 cohorts, we come up with 926 patients in this study population. And I might point out that data for these analyses are blinded and maintained by McLeod Consulting, and independent statistical analyses were performed. Just overall, about 2/3 of the patients received radiation and about 1/3 hormone treatment. And so when we look at these 926 patients and try to identify them into low-risk populations using various definitions, on the far left, we look at the molecular 7-gene biosignature applied to these 926 patients, and 38% of them would be defined as low risk with a decision score less than or equal to 2.8. In the middle, we use the RTOG 9804-like criteria, and 51% of the same patients would be defined as low risk. And on the far right, we look at the Memorial Sloan Kettering nomogram applied to these 926 patients, and we see that only 34% of them are defined as low risk. But let's specifically look at the RTOG 9804 low risk patients. In other words, of the 926, 51% of them were identified as low risk. And when we look at their 10-year outcome, we see that there was a statistically significant benefit, even after being defined as low risk, using RTOG 9804-like criteria, with about a 50% relative reduction in the risk of local recurrence. But now if we take those 473, quote, low-risk patients as defined by RTOG criteria, and we apply the 7 biogene signature, we see that 51% of them are now reclassified as high risk using the biosignature. That is a decision score greater than 2.8. Specifically looking at these for 241 patients, when we looked at their 10-year outcome, there was a statistically significant benefit in the risk of local recurrence. In other words, there was about a 70% relative reduction in the risk of local recurrence in these patients defined as low risk using 9804 criteria were reclassified as high risk with the biosignature. And when we look at the 49% of them that remained low risk using the biosignature, indeed, there was no statistically significant benefit in the risk of local recurrence with radiation at 10 years. Now let's look at the Memorial Sloan Kettering nomogram. As I mentioned previously, of the 926 patients, 34% of them were identified as low risk using the Memorial criteria. When we look at their 10-year rate of local recurrence, despite being identified as low risk, at 10 years, there was a trend towards benefit from radiation, with about a 50% relative reduction in the risk of local recurrence. But now if we focus on these 320 patients defined as low risk with the biosignature and apply the 7-gene biosignature, we see that 63% of them, or 202, are now defined as high risk with a decision score greater than 2.8. When we look at the 10-year outcome in these 202 patients identified as high risk with the biosignature, we see a statistically significant benefit in the risk of local recurrence at 10 years with radiation therapy. So again, these are Memorial Sloan Kettering identified as low risk, 63% reclassified as high risk with the biosignature, and they showed a pretty dramatic reduction in the risk of local recurrence with radiation therapy. Looking at the low risk criteria patients, molecular low risk, we can see again at 10 years, there was no significant benefit from radiation therapy in these groups of patients. What you see on this busy slide on the left, I have the various criteria identifying low-risk patients applied to these 926 patients. We look at the Memorial nomogram, the RTOG, Van Nuys, and various ways of defining low risk. And when we apply the 7-gene biosignature in all of these patients classified as low risk, we see about 50 to 2/3 of them being reclassified now as high risk, and all of them having a statistically significant reduction in the risk of local recurrence, despite being defined as low risk using Clinpath criteria, being then reclassified with the molecular gene biosignature to high risk, and then looking at their 10-year outcome. So what can we conclude from all of this? Well, our data demonstrate that about a 50% of patients considered low risk by all the various Clinpath criteria definitions are actually high risk when you apply the 7-gene biosignature, and just as important, have a statistically significant benefit from radiation at 10 years. Obviously, the 7-gene biosignature more reliably identified patients with low 10-year rates of local recurrence and no significant benefit from radiation than traditional Clinpath low-risk criteria. That is, RTOG 9804 and Memorial Sloan Kettering-like criteria. I think the take-home message is that the biosignature provided unique information not available in the Clinpath criteria to help prevent over and under treatment of patients with low-risk Clinpath criteria. So what are future studies? Well, we've proposed cooperative group prospective randomized trials for patients considered low risk using Clinpath criteria, and then stratified by the DecisionRT molecular testing. And the concepts are under review currently. Thank you for your time.